Welcome everyone, and welcome to our second National RDAA Grand Rounds. We'd like to welcome any new faces that are here joining us. We wanted to start by acknowledging the traditional owners of the land on which we meet across Australia, and I'd like to pay my respects to their elders past, present and emerging, and thank any Aboriginal Torres Strait Islander people who are joining us tonight. We are part of the Rural Doctors Association Doctors in Training Group. We meet every 3 months and we welcome new members. And tonight we are very fortunate to have one of our very own, Dr Ben Dodds from Tasmania, to be presenting a very interesting case on some spicy chest pain. So thank you for joining us, and Ben, take it away.
Which is about an hour northeast of Launceston. I'm going to tempt fate tonight, and we're going to try and use some technology. So if you can get your phones out and join Slido via the QR code, I'll give you a little bit of time to do that. There'll be some questions that will pop up as we go. I'll just give you a little bit of time to sign into that. Marion, please feel free to move me along when you think that we've had enough time.
We'll give everyone another 30 seconds, Ben. I'm so excited you're using some technology.
Yeah, well, you just never know, do you? Now, please don't want this to be like a didactic Zoom lecture, which I'm sure we're all well and truly sick of in this day and age. So if you want to interrupt me and ask questions or put something in the chat, Marion will monitor that for us. And if you want, I will have a few questions to the group, so that this is not just me talking so much. Please jump in and give us an answer. So I'll move us along. I'll get this to work. So the first question is, I just want to know who everyone is and what they do. If you can give that a bit of a whirl for me. Ooh. We got 7 people signed in, which is good. Perfect. Okay, so good mix of students, doctors in training, and one other who I'm not sure. Whoever's other, would you like to vocalize who you are if I haven't been able to?
It's Peter.
Peter other, is she? Oh, okay. Peter's participating. Peter's got to get the medical questions right. She's been around doctors for long enough. She should have learnt a thing or two by now. Perfect.
So an honorary medical degree, Ben.
So the context is I'm working in a rural hospital. We have 18 beds, 3 emergency beds, and we work as an on-call GP roster. So you work during the daytime, see some patients in the clinic, see some patients in the hospital, and then you're on call overnight for the hospital. On site, we've got 2 RNs, access to ECG, iStat bloods, a fairly basic point of care ultrasound. We're a farming community. We've got about 6,500 people in the region. We've got quite wet, windy roads down here in Tassie, and we're about 65 kilometres or 1 hour from the nearest regional hospital. So we're not too far away. Everything's pretty close by where we are. So a 72-year-old man, I get a call from the nurse. He's coming with chest pain. It started tonight. He'd been at his granddaughter's birthday party, and he ate a spicy lasagna and had a beer. And then about an hour later, developed some chest tightness and breathlessness. And I get to the emergency department to see him, and he goes, "Doc, it's this lasagna. It's just upset me." And I look at this fella and he looks like shit. So I thought I'd ease us in with a nice question to begin with. So what are some common causes of chest pain? Now, if you type them into the poll, they should pop up on the screen for us. Now, Peter, you should be able to answer this one. Good. And this word cloud, what it will do is if more than one person answers the same question, the same response, it will get bigger on our word cloud. So obviously gourd is a top hit at the moment, which makes sense. Man's had some food and some beer, and now he's got significant chest pain. Good. So I'll move us along from that. I think that's all some very reasonable differentials for chest pain in a 72-year-old male. What would you do next, or what would you like to do next? Throw out what would you like next. Yeah, call for help. I like that one too. ECG's up there. Good. So I'm seeing some good structures here. So we're calling for help. We want observations. We want a structured A to E assessment. We want to do a history and examination. I think you guys will be just fine. So further history, he's feeling a little bit unwell today. He wasn't quite his usual self. He'd been at the party, he'd had the lasagna, and then about an hour later he developed his symptoms, and he'd had them for about 2 hours before he presented to the hospital. And it's about 10:30 at night now that he's come in. Nothing else significant in the last couple of days. He's got a background of cardiomyopathy. He's known to a private cardiologist, but he hasn't really seen them for 3 or 4 years now. He's got gout, osteoarthritis, and he's had a couple of hip replacements. He's on a beta blocker, an ACE inhibitor, and some aspirin daily. But otherwise, he's a pretty fit farmer. So I don't know if you've seen the Glockenfeck videos recently, but he is a farmer, and that is a red flag. So I look at him, and he looks unwell. Just from the end of the bed, you go, this man doesn't look quite right. He's quite distressed. He's holding on to his chest. He's tachycardic. He's hypoxic. He's sweating. His obs are as follows. So he's got a heart rate of 150. He's got a good blood pressure. He's got stats of 90% on room air. We'll have a look at his ECG in a second. On chest examination, heart sounds are dual. There's a systolic murmur. Lung fields are clear. Tummy soft, non-tender, and there's no overt signs of cardiac failure. Now, I didn't take this photo of this ECG with having a presentation in mind, but I'll give you just a little bit of time to have a think and look through this, and then we'll go through what your immediate concerns and interpretation of that might be. And I'm definitely not going to pick on anyone to try and interpret an ECG over Zoom at 8 o'clock at night, because that's just mean. Now, I'll give you the benefit of the doubt by showing you another one that's about an hour later, that's a little bit slower and a little bit easier to interpret as well. Good. So who wants to have a guess at what this ECG shows? Come on, guys. Someone's got to commit to the cause. Is that poll coming up okay for you, Marion?
Yep, I selected the I can't read ECGs option.
Oh, okay. Well, it must still be loading. I think you can interpret ECGs. Only 5 votes, so we'll give you one more chance to lock in your answer, Eddie.
We're waiting for you, Peter.
Yeah. Peter, what do you think? Oh, anyway, I clicked the button. So my interpretation at the time, this is a broad, complex, regular tachycardia. Rate's about 150 beats per minute. And there's some ischemic changes, probably most evident in V5, V6. And I'll be honest, I looked at this ECG and I thought, this doesn't neatly fit into a pattern that I recognize. I can't go, yep, that's AF, or yep, that's an SVT. Looked at it and I thought, this just looks weird. I got a man with chest pain who's tachycardic, normotensive, and has a weird looking ECG. What could it be? Well, broad complex tachycardia, could be VT, could be AF, could be SVT with aberrancy. So basically it could be anything, and I still don't really know what it is, and all those things will be treated differently. So it's not helped me at all, has it? So what the hell do we do now? So I'll set the scene. When you're thinking about preparing yourself for a resuscitation scenario or preparing yourself for exams, it's good to have a little process that you go through. So I start with an acronym called PEDS. I go, people, okay, so there's me. I'm going to be the team leader, the airway doctor, the drugs doctor, the circulation doctor, and the procedural doctor. And that's a bit of a red flag. I think, actually, I probably need to call for help now, don't I? So in how we run our roster, we have a second on-call GP supervisor. But depending on where you are, that help might be retrieval or your nearest base hospital. I've also got 2 ALS nurses that can help me, which is good. Area to care for this man will be resus, and I put that in inverted commas because this is actually a photo of what my resus bay looks like in Scottsdale. So it's 1 bed. There's not much there. There's a red crash cart trolley, a defib, and a monitor. And that's about all I have access to. I've got my airway, breathing, circulation, defibrillation, and I'm thinking drugs that I might need to use: fentanyl for pain relief, aspirin for possible ACS, adrenaline and amiodarone if we move to an arrest scenario, and IV fluids to keep the line open. So what would you like to do next? So we don't really know. We've got a broad complex tachycardia. I've got a man with chest pain. He looks like crap. You need to do something. What would you like to do? And when I say electricity, I mean cardio, but not connect into the electric fence. So it looks like people are thinking compromised man, electricity might be useful, or SVT, or possibly another rhythm that adenosine might be able to unmask and find for us. So that is good. Thank you. So I obviously called in the GP consultant that I was working with, and whilst that was happening, we got on the phone to our retrieval consultant, who said, look, they're not sure what the interpretation of the ECG is either, but let's treat it as the most serious pathology, which would be conscious VT. Now, in a man with conscious VT, there's sort of 2 different ways of treating it. If he's hemodynamically stable, you've got some time and you can attempt some chemical cardioversion. If he was hemodynamically unstable, you might move towards cardioversion quite quickly. And then the base hospital also got wind that we were sending them a patient and wanted copies of the ECG. And I quite liked their reply, which is, we're just looking through life in the fast lane, and we think it's SVT or a flutter, but we don't think it's VT. So now I've got two conflicting bits of information. I've got a retrieval consultant telling me one thing, and I've got the FACEM in the base hospital telling me another. And of course, the fax machine wouldn't work at 11:30 at night, because they never do. A bit more information about the patients. So we managed to get some bloods and a gas off. So electrolytes are unexciting, VBG is unexciting, glucose is normal, and his troponin is positive or elevated on our iStat machine. What we did do for him was we gave him some aspirin in case this represented acute coronary syndrome, some fentanyl as analgesia, but judiciously without dropping his blood pressure too much. And we actually opted, in conjunction with retrieval, to give him 300 milligrams of amiodarone as an IV loading dose, thinking that would help treat a VT. It would also help cardiovert an atrial fibrillation. And then if he deteriorated, pads on, get ready to shock. Now, in classic pharma style, as his heart rate dropped and his rate-related ischemic changes disappeared, his chest pain got a lot better. And he goes, I'm feeling really good now, doc. I think it was just that lasagna. Can I go home now? To which I very sweatily replied, no, you need to go see the cardiologist tonight. Luckily, we had relatively prompt arrival of our ambulance retrieval service who took him to the base hospital about an hour away. When he arrived there, he'd reverted back to a heart rate of 80. He had an underlying left bundle branch block, no chest pain. They weren't really sure what the rhythm was there either, so they just kept him overnight. The cardiologist came round in the morning, thought maybe that was SVT, maybe it was atrial flutter. We're still not really sure either. And then that was the ECG when he arrived in Launceston in the emergency department. So that heart rate is 80, looks like we're back in sinus rhythm, and there's some left bundle branch block changes there as well. So a much nicer looking ECG than the one we had before. Because it is a grand round, it's probably reasonable that we try and learn something along the way. So just broadly classifying arrhythmias, we can think about them as bradyarrhythmias or tachyarrhythmias. Focusing on the tachyarrhythmias, we then sort of delineate further into narrow complex or broad complex tachycardias and look at whether those rhythms are regular or irregular. So our narrow complex tachycardias, we think sinus tachy, atrial flutter, SVT, Wolff-Parkinson-White syndromes, and irregular narrow complex tachycardias, atrial fibrillation. A broad complex tachycardia like this man, it was regular. Could be a VT, could be a pace rhythm that's become tachycardic, could be sodium channel blockade, QRS widening, or it could be any of those other tachycardias that have a background of bundle branch block or an aberrancy or a pre-excitation syndrome, which doesn't really help us. And, I think that last one, the aberrancy, the bundle branch blocks, is sort of getting into the territory of the fancy cardiology doctors rather than us rural generalists out in the countryside. And then irregular broad complex tachycardias, we're thinking more polymorphic VT, irregular VT, VF, or AFib, A-flutter. And there's a big long list of precipitants that you could think about. And I think it was very clear that a lot of these were not going to be excluded in the hospital that I was working in and required further investigation. And lasagna is not a precipitant of tachyarrhythmia as far as I'm aware. So a good thing about working across general practice and hospitals is that you get to follow up your patients and you find out what happens to them. So he went and saw his private cardiologist a few weeks later, and he I guess, had the final say, and he described that initial presentation as probably an atrial flutter on a background of a left bundle branch block that reverted to sinus rhythm with a left bundle branch block with the amiodarone. Over the next little while, this fella got a bit worse. So he had that cardiomyopathy and his left ventricular ejection fraction fell. He became decompensated from his heart failure. He had several admissions for diuresis. He went on to have an angio that showed several critical stenoses and also a severe aortic stenosis. He eventually was so extreme that he was admitted for diuresis and urgently transferred down to our tertiary hospital for cabbages and aortic valve replacement. Interestingly, reading through the notes there, he actually had a Met call for AF where they gave him amiodarone and he reverted back to sinus rhythms. So vindication that we probably did the right thing at the time. And then if you follow down your heart failure guidelines, ongoing symptoms of CCF, there's an indication for a pacemaker. So he came in and saw me, and verbatim, he sat down and he says, "I feel like a new man." He's going to be out there back in the farm picking up spuds again. And he's normotensive and normocardic with still his persistent atrial fibrillation and no overt signs of failure. So he's had a relatively good outcome from all this. So the learning points from tonight's session is that rural generalists have a wide skill set. You never know what's going to come through the door next. You can do a lot for yourself, but you can always ask for help. Sometimes you don't know the answer, and that's okay. But you look at this man and you go, he's sick, he's got a broad complex tachycardia, he's going to exceed the resources that this hospital can provide, and I can start a safe management approach that's going to provide initial care before he is retrieved. I think continuity of care provides significant job satisfaction in rural journalism, in that we know our patients from the community, we see them in the hospital, and then we follow them back up in the community, and patients are really appreciative of that, and certainly I think is a highlight of our job. And we've just had a brief discussion about the assessment of tachyarrhythmias tonight. If you can't automatically look at something and know exactly what it is through pattern recognition, there's always something to fall back onto, which is a system of analysing ECGs, which is very helpful. And for those of you that are wanting to know a bit more about RDAA and Destination Rural, then as students, you can join your local rural health club through the university, the doctors in training. There's the Rural Doctors Association in each state. We have our Doctors in Training Special Interest Group, which meets semi-regularly. You can contact Peter at the office. If you want to get to know each other in person, please consider coming to the Rural Medicine Australia conference in Canberra. It is a lot of fun, make a lot of friends and learn about lots of different opportunities for placements and posts when you're in training. And if you have any specific Tasmanian rural journalist pathway questions, feel free to shoot me an email. We're always keen to have people move down and experience what we have to offer down here in Tassie. And that's the end for me, Marion.
Well done, Ben.
That's all right. Did anyone have any particular questions or concerns, or were like, man, you're an idiot, you should have known what that ECG was the whole time?
While we wait for questions, Ben, I think I just want to reflect with you, agree with all the points that you came out with at the end. I think you did a fantastic job. It's always interesting seeing, how someone could walk in with anything. You don't know what they're going to walk in with at 10:30 at night, and could have been a foreign body, could have been, anything obscure. But regardless of what it is, we're very good at stabilizing these patients and buying them extra time until they can get that sort of one-on-one care in a tertiary centre. So well done. I thought that was a very good case to highlight our role. Very impressive.
It was quite interesting because by the time he got to Launceston, there wasn't actually anything for them to do. He'd had his cardioversion chemically, and he sort of just sat there waiting for specialist input, and they sent him home the next morning. They didn't keep him for any investigations.
Brilliant.
Yeah. you don't always think you're doing the right thing at the time, but you can find out later that it worked and it's a good feeling.
Well done, Ben. I think it's also interesting, you know, we always doubt ourselves when we're reading ECGs, but there were people disagreeing with each other on the other end of the line. So yeah, I think that was a very, very job well done.
Does anyone online have any questions or any points they wanted to raise?
Yeah, I suppose it's just something I wanted to ask about. Great presentation, Ben. That was very interesting. And yeah, it must have been a bit of a fist pump moment when even the consultant cardiologists were umming and ahhing about what the hell that ECG actually was. I suppose it's a good case where you sort of just have to come back to basics and think about, like there's tachycardia on the ECG, we'll just manage it from there instead of, figuring out a very specific diagnosis. Just a question, was there any consideration given to potentially shocking this patient? Just with guidelines, if there's features of instability, so like one of which is myocardial ischemia, which I suppose a guy with chest pain and ST changes with the tachycardia, maybe there could have been consideration for shocking them. Was that something that that retrieval considered, or?
It was something we considered, but at the time of night probably was more resource intensive than what we would be able to achieve from a skill set perspective, in that it would have just been me and one other doctor and nurses that would not probably be that comfortable managing an airway or post-sedation apnea or something like that. And I think what we held on to was that despite the chest pain, he still had relatively good blood pressure, and maybe we had some time to try the chemical stuff first before we went down the electricity pathway. If it was to happen again in the middle of the day with more doctors and people around, would we just shock him? Yeah, probably. It was probably not a bad idea. It would have set things up one way or another. You would have found out whether it was a refractory arrhythmia or not. Would he get shocked in a big emergency department? Probably. I think he probably would. But I think we went with an option where we could give him a medication, review his response, and if it didn't work, move on to the next thing.
Yep, no, definitely.
I think the drawbacks of giving amiodarone were relatively few in that moment in time, whereas the reality of sedating a potentially unstable man and creating an arrest scenario at night in a rural hospital could be catastrophic. But if he had no blood pressure and you had nothing else to do, I think you would move down that pathway.
Yeah. Also a good demonstration of you're just doing what you can with the resources you have.
Can't even remember who the nurses that were on now. But yeah, normally they're pretty good, but something like this is pretty scary for them, especially because there's usually one RN and one EN overnight as well. So yeah, not all of them have had much emergency exposure.
Thank you.
Thanks, Marty.
Are there any other questions amongst the group? The stunned silence, Ben.
I'm just reading the chat. Texaco Mike. Needed him.
I love that video. As you guys walked into the chat room tonight, you were entered into a lucky door prize. And the prize tonight is an Apple airbag. So without further ado, our winner of the lucky door prize is Lachlan Philpott. Ooh, congratulations. And a tag, a tag.
Non-Apple.
Not a bag, a tag, sorry. That's my dyslexia. But congratulations. Dr. Peter will actually be in touch with you to get your postal address and we'll send that out to you. So congratulations. any other final remarks or questions before we call it a night? Congrats, Lachlan. But yeah, I think a big thank you to Ben for the fantastic case that you shared tonight that highlights how fantastic a job it is to be rural, whether you're a rural generalist or any other specialty. Everyone's welcome, and everyone's very much part of the team. Our next session will be in 2 weeks' time. Dr. Dan Wilson will be presenting a really interesting case. He's already started to tell us about it. And yes, we look forward to seeing you again. Make sure you register for the next session as well. And anyone who's coming to RMA, please come and give us a yell when you see us around. Otherwise, you'll probably hear from Peter about our next meeting for the Doctors in Training group if you're interested. Thank you, everyone, and well done, Ben.
Thanks, everyone, for your participation.